All right. Well, so my name's Andrea Nederveld. I'm a internal medicine pediatrics trained physician. I work in the Department of Family Medicine because Colorado doesn't have very many med peds physicians, but I practiced for a long time clinically in community-based settings and then transitioned over to research because of this interest that I have in really, why is it so hard for people to be healthy, especially people who are who don't have resources. I don't want to use the wrong term, but people like that. So, this project actually, Alina Broadus, who's here in the audience, did a lot of the analysis here as part of a fellowship that she was doing in primary care research. So if there are questions on the methods at the end, Alina's probably the person to answer those, but I will go through what we found. So the background on this, so Alina and I received funding from SIREN actually in their call for proposals that was really aimed at trying to figure out why patients don't always accept help with social needs. We called our study Imagine, so it was the Improving Messaging and Gaps in Needs and Referrals study. And that study went from January 2020 to December of 2021. And through it, we developed and tested improved strategies for communicating with patients about social needs screening and referral. So that was kind of the overall study. This analysis is using that data that we gathered for the Imagine project to look at factors that influence patient comfort with screening and perceived helpfulness of screening for social needs. So just the theoretical perspective that we took thinking about this was really around relationship-centered care, and we've heard a lot about that at this conference from other presentations, but really emphasizing the importance of communication and relationships among patients, their clinicians, and then the wider network of individuals involved in clinical care. So everybody knows you don't typically go to a clinic visit or a doctor's visit and just interact with your clinician. You interact with a whole team of people. And all of those people have the potential to influence comfort and helpfulness perceived around social screening. This theoretical perspective also suggests that the extent to which patients are comfortable with social needs screening and find it helpful depends on their own lived experience as well as those practice level factors. And this is just showing where our work was done. So Elena and I, neither of us live in Denver. We both live in Western Colorado, in more rural areas, and importantly, pretty far away from the academic center that we work for. The area that we live in is primarily non-Hispanic white. You can see the stats there, 80% Hispanic white, 7%, and then 2 or more races, 6%. There's pretty high prevalence of social needs. So if you look at Western Colorado counties compared with the Denver metro area, our percentages for most social needs are higher. And our whole side of the state participated in the AHC initiative, as did an area in Denver. So as far as where we gathered this data, it was 3 primary care clinics, and these are the 3 that participated in the Imagine study. They're members of a PBRN network called Partners Engaged in Achieving Changes in Health. That is a Western Colorado practice-based research network that Elena and I co-direct. All 3 were safety net clinics, so 45 to 49% across the 3 of patients covered by Medicaid, large chunk of the rest by Medicare or uninsured. And they were all participating in the AHC initiative. So they all had been implementing social needs screening and referral. So just in case you don't know, I think probably everybody here knows, this is the AHC screener. The clinics were screening for the 5 core needs that they were required to screen for, as well as loneliness and social isolation. So the methods for this mixed methods, kind of looking at the data around helpfulness and comfort, we use the quantitative data from our from surveys given to patients. So I'll quickly tell you, the Imagine trial, we ended up looking at 3 different ways to introduce social needs screening. One was not to introduce it, basically, to just hand people the form with the AHC explanation on the front. And for people who haven't seen it, it was kind of dense writing. I mean, it was aimed at a literacy level that we often think is okay, but it's a lot of words and probably people didn't read it very much. The second was using a top sheet that we created through a community engaged process with messages actually very similar to what we just heard about people wanting to know why, wanting to know what would be done with the data, normalizing it. And then the third was having an MA explain it as they were rooming the patient. So that sometimes changed the workflow for clinics, but it was how we got this data. So these 511 surveys are from people who participated in one of those arms, and then after they were screened, completed a really short survey about their comfort and their perceived helpfulness. The qualitative data was based on interviews we had done with primary care patients from these 3 clinics who had gone through the social needs screening and referral process. Elena then did some logistic regression analysis and identified factors associated with patients reporting that they felt comfortable, so in response to our little short survey, or thought that it was helpful. And then also performed a narrative analysis, so looking at all of these interviews and kind of building stories based on how the people answered the question. So it was kind of like life story narrative analysis of these interviews. And then put that together to compare the regression and narrative analysis results to really look at the convergence of those results and also how the qualitative findings expanded on the quantitative findings. So results, this just shows who responded to our survey. So you can see the 511, most people reported that they didn't receive an explanation. And again, that's across all 3 arms. So it's the arms where they just got it from the front desk, where they got the hopefully simplified written explanation, and then the verbal explanation. You can see that 76% were the front office or the front desk receipt of the form. So that would be the people with the written forms only. And 24% from the MA. That was across the 3 clinics. You can see the number of needs. So about half of the people who responded had at least 1 need, and 13% had 3 or more. Income category, the largest percentage of people is in that 10,000 to 35,000, and then age was distributed, biggest group being 40 to 64, which is, the most common group of people to go to the doctor as well. More women than men, and about our local, our what we would expect demographically for Hispanic or non-Hispanic. This was the interview demographics, so pretty similar to what you saw on the survey demographics. We also asked about education level there. So these were the logistic regression results. So I know it's a lot of numbers, but as you can see, there's a red box pointing you to some of them. And the first thing really to notice is that patients who said that they had received an explanation of the reason that they were being screened were significantly more likely to report feeling comfortable with screening and to report that they thought it was helpful. So we don't know which arm necessarily people were in for that, but obviously important for people to feel like they know why you're asking in order for them to be okay with it. And I think very similar to what we heard in the previous presentation. The other, which was kind of the opposite of what we maybe initially hypothesized, was that there was an inverse relationship between the number of needs that a patient reported and comfort. So people with 2 needs or 3 or more needs were really less likely, significantly less likely to report that they felt comfortable. Excuse me. So how did that, integrate with our narrative results? So the narratives showed how the extent and duration of a patient's social needs and their experiences with the healthcare team influenced their comfort and perceived helpfulness of social needs screening and referral. So that helped to explain and also expanded, obviously, on our quantitative findings. And just so you know, the published paper includes several examples of these narratives if you feel like reading them. We don't really have time to read them today. But basically, they fell into kind of 4 categories, and you can read about that in the paper if you want. So integrated findings, how did we put this all together? So first, patients' experience with social needs. So our quantitative, again, was that those experiencing more needs were significantly less likely to say they were comfortable with screening compared to patients with fewer needs. The convergent qualitative findings really showed that those with long-term needs in those interviews described more exposure to stigmatizing experiences. So they, if they had experienced needs for a long time, obviously they had had more interaction around those needs and more chance to feel stigmatized because of them. Excuse me. And also that those stigmatizing experiences really contributed to that greater discomfort. So you can see why that would be true. And then expanding those qualitative findings, so with a narrative analysis, those with extensive long-term needs often described negative or unhelpful past experiences trying to access assistance. Those negative experiences really seem to contribute to greater skepticism about the helpfulness. So I think I have water. I knew this was going to happen. I'm fine. This is actually 3 months old, too, for any of you who think I might have COVID. I just had something that lasted a really long time, so I'm sorry about that. The second thing, patient experiences interacting with the healthcare team. So those receiving the explanation about the purpose, more likely to report comfort, perceiving it as helpful. And again, those who described good communication felt comfortable and thought it was helpful. Those who described poor communication or limited communication indicated more discomfort. So again, relationship quality really matters. Negative relationships contributed to discomfort with and skepticism about the helpfulness. And positive relationships contributed to comfort. So that all makes sense, right? As human beings, we kind of can see why that would make sense. So our key takeaways, so the importance of explanations about social needs screening and referral for all patients. We can't just give people a form. People need to understand why we're asking. Patients with more needs feeling less comfortable, that could be due to these context-specific attitudes towards social needs and assistance. And again, the area of the state that we live in tends to be maybe a little more conservative, potentially judgmental based on some other work we've done. Patients with limited needs, referrals were a valuable source of information because they weren't that familiar. They hadn't maybe had a long experience of trying to meet their needs. Patients with extensive needs, that relationship with healthcare was key, and determined whether they saw screening and referral as intrusive and patronizing versus caring and supportive. When practice relationships are good, screening and referral can still be a positive experience for patients, even if it doesn't result in new resource connections. And I think we've heard a lot about that too. So implications for you as clinicians, if that's what you are, clearly explain screening and referral processes using patient-friendly messages. Acknowledge past experiences people may have and ask them, what have you already tried? So don't assume like you have the answers to these problems that they've been living with for a really long time. Consider the patient's history and rapport with the practice when deciding if and how to screen. And something that we've been thinking a lot about is structural competency training. So, when we start things like this that are kind of maybe not anymore, but at least initially we're kind of outside of what we considered to be the realm of medical care. You can't expect everyone to just understand it and be on the same page staff-wise. Like, it's important that people under your clinical staff understand why we're doing this. So it was small, diversity somewhat limited. We didn't interview any Spanish-only speakers because we didn't have a Spanish-speaking interviewer. But that would have been helpful. Our survey really only captured perceived helpfulness at the time of screening, so we didn't have a follow-up measure for, after the fact, did people feel like, oh, actually that did help me, or didn't, and need for longer-term follow-up, as we've heard from multiple speakers at this conference. So again, thank you to SIREN for funding our work. Alina was funded by the Accords Primary Care Research Fellowship, another clinical researcher and I also participated in this, and mostly thanks to our clinic staff and patients who participated, because we couldn't have done it without them. And then if you want to see that paper, the slides are uploaded, so you can find it there. Thank you.